Welcome to A Sound Constitution on 101.7 CHLY Radio.
A health promotion show brought to you by VIU nursing students.
Over the next hour, we will be demystifying health issues.
Thanks for tuning in.
Good morning, listeners, and welcome to this Thursday's edition of A Sound Constitution on 101.7 CHLY in Nanaimo. My name is Allison, and in the studio with me today is Brittany, Jade, and Sophia. Special shout out to Julia for being our tech whiz. Today's show is all about older adult health and how to live your best life after age 65. Old age refers to age nearing or surpassing the life expectancy of human beings, and is thus the end of the human life cycle. Terms and euphemisms used include old people, seniors, senior citizens, older adults, the elderly, and elders. Older adults often have limited regenerative abilities and are more susceptible to diseases, syndromes, and sickness than younger adults. The organic process of aging is called sustenance. The medical study of the aging process is called gerontology. And the study of the diseases that afflict the elderly is called geriatrics. The elderly also face other social issues around retirement, loneliness, and ageism. Old age is not a definite biological stage, as the chronological age denotes as old age varies culturally and historically. Continuing with our theme of following Erikson's psychosocial development theory, today we're talking about the 8th stage, integrity versus despair. This stage begins at approximately age 65 and ends at death. Erikson's theory suggests that people pass through 8 distinctive developmental stages as they grow and change through life. While many developmental theories tend to focus purely on childhood events, Erikson was one of the few theorists to look at the development across the entire course of a lifespan. He was also one of the first to view the aging process itself as a part of human development. At each stage of psychosocial development, people are faced with a crisis that acts as a turning point in development. Successfully resolving the crisis leads to developing a psychological virtue that contributes to the overall psychological well-being. At the integrity versus despair stage, the key conflict centers on questioning whether or not the individual has led a meaningful, satisfying life. The integrity versus despair stage begins at the beginning. Aging adult begins to tackle the development or the problem of his or her mortality. The onset of this stage is often triggered by life events such as retirement, the loss of a spouse, the loss of friends and acquaintances, facing a terminal illness, and other changes to major roles in life. During this period, people reflect back on their life and to see whether they have lived and come away with either a sense of fulfillment from a life well lived or a sense of regret and despair over a life misspent. Successfully resolving this crisis at this stage leads to the development of what Erikson refers to as an ego integrity. People are able to look back at their life with a sense of contentment and face the end of life with a sense of wisdom and no regrets. Erikson defines this wisdom as an informed and detached concern with life itself, even in the face of death itself. Those who feel proud of their accomplishments will feel a sense of integrity. Successfully completing this phase means looking back with few regrets and a general feeling of satisfaction. These individuals will attain wisdom, even when confronting death. That's all for me now. Hope you enjoyed today's show as we explore the wonders of older adults and discuss important topics for our listeners to make informed decisions to help promote the health of the aging community.
Thanks, Allison. Hey, listeners, it's Sophia here. Thanks for tuning in to A Sound Constitution. Today we are looking at the health of older adults. So, some bad news first. According to a recent CBC News article, when frail older patients have an acute health crisis in Canada, our health system usually delivers excellent service. Well, wait, that's good news. But health and quality healthcare is determined by more than just a response to medical emergencies. The truth is, our health system often fails when it comes to addressing the complex care needs of frail or older adult patients between urgent health events. More Canadians are 65 and over than under age 15, Stats Canada says, so you would think that there would be more emphasis on addressing this. We rarely deliver quality chronic care, comprehensive home care, or continuous care, and in particular, poorly handle transitions between care settings and providers. We often also neglect more cost-effective interventions with proven health and quality of life benefits, such as social supports that can help people age in place. Our overemphasis on acute care leads to the consequent neglect of other aspects of the health system have serious consequences. From this news article, it would appear that there is little support for the transition to older adult healthcare needs. But I'm also here to share some good news. Do you ever find yourself thinking things like, the stairs are getting so hard to climb? Since my wife died, I just opened a can of soup for dinner. I've lived here for 40 years. No other place will ever seem like home. These are common issues for older adults. You may share the often heard wish, I just want to stay in my own home. The good news is that with the right help, you might be able to do just that. United Way has a service called Better at Home, supporting the non-medical care needs of older adults in BC. Better at Home is a program that helps seniors with simple day-to-day tasks so they can continue to live independently in their own homes and remain connected to their communities. The Government of British Columbia funds the program, United Way of the Lower Mainland manages it, and local nonprofit organizations provide the services. Its unique Seniors Planning for Seniors approach means older adults contribute to the design, operation, and evaluation of their local programs. So let's look at some of the services available. Volunteers, contractors, and paid staff from local nonprofit organizations provide Better at Home services. By helping seniors remain at home longer, they support a diverse, inclusive, and vibrant neighborhood for everyone. A range of non-medical home support services are available. Better at Home services vary from community to community. They are designed to complement existing services and are based on the unique needs of local seniors. Some examples include friendly visiting, transportation, yard work, minor home repairs, housekeeping, grocery shopping, and snow shoveling. Help is close to home. Seniors living in a community which offers Better at Home, which, good news, is us on Vancouver Island, can contact the local organization to find out more and to apply for services. A service provider will help determine which services are most important for an individual circumstance. Want to know even more? Contact the program by emailing info@betterathome.ca or visit their webpage, betterathome.com, for more details and contact information. Next, let's look at some further strategies you can do to extend your potential for living in your own home as long as it is safe to do so. Plan ahead to stay in your home. Planning ahead is hard because you never know how your needs might change. The first step is to think about the kinds of help you might want in the near future. Maybe you live alone, so there's no one looking after you in your home who is available to help you. Maybe you don't need this right now, but you live with a spouse or family member who does. Everyone is in a different situation. One way to begin planning is to look at any illness, like diabetes or emphysema, that you or your spouse might have. Talk with your doctor about how these health problems could make it hard for someone to get around or take care of him or herself in the future. If you're a caregiver for an older adult, learn how you can get them the supports they need to stay in their own home. It's also important to be prepared for an emergency. If you were to suddenly become sick and unable to speak for yourself, you probably would want someone who knows you well to decide on your medical care. To make sure this happens, think about giving someone you trust permission to discuss your health care with your doctor and make the necessary decisions. Learn about healthcare advance directives. Talk with your doctor about whether you should get a medical alert ID bracelet or necklace. Hopefully this information has left you hopeful for the years to come. And don't forget to check out the Better at Home resource that can help you stay in your home longer if this is a concern for you. Stay tuned because up next we have Allison. Let's hear what she has to share with us today.
Thanks, Sophia. Up next, we're going to talk a little bit about mental health in the older population. The World Health Organization is a great resource to learn more about mental health for all ages. Older adults, those aged 60 or above, make important contributions to society as family members, volunteers, and as active participants in the workforce. While most of these have good mental health, many older adults are at risk of developing mental disorders, neurological disorders, or substance use problems, as well as other health conditions such as diabetes, hearing loss, and osteoarthritis. Furthermore, as people age, they're more likely to experience several conditions at the same time. The world's population is aging rapidly. Between 2015 and 2050, The proportion of the world's older adults is estimated to almost double, from about 12% to 22%. In absolute terms, this is an expected increase from 900 million to 2 billion people over the age of 60. Older people face several physical and mental health challenges, which need to be recognized. Over 20% of adults aged 60 and over suffer from a mental or neurological disorder, excluding headache disorders, and 6.6% of all disability among over 60s is attributed to neurological and mental disorders. These disorders in the elderly population account for 17.4% of years lived with disability. The most common neuropsychiatric disorders in this age group are dementia and depression. Anxiety disorders affect 3.8% of the elderly population. Substance use problems affect almost 1%, and around a quarter of deaths from self-harm are among those aged 60 or above. Substance abuse problems among the elderly are often overlooked or misdiagnosed. Mental health problems are under-identified by healthcare professionals and older people themselves, and the stigma surrounding mental illness makes people reluctant to seek help. Multiple social, psychological, and biological factors determine the level of mental health of a person at any point of time. As well as the typical life stressors common to all people, many older people lose their ability to live independently because of limited mobility, chronic pain, frailty, or other mental or physical problems. It requires some form of long-term care. In addition, older people are more likely to experience events such as bereavement, a drop in socioeconomic status with retirement, or a disability. All of these factors can result in isolation, loss of independence, loneliness, and psychological distress in older people. Mental health has an impact on physical health, and vice versa. For example, older adults with physical health conditions such as heart disease have higher rates of depression than those who are medically well. Conversely, untreated depression in an older person with heart disease can negatively affect the outcome of the physical disease. Older people are also vulnerable to elder abuse, including physical, sexual, psychological, emotional, financial, and marital abuse. Abandonment, neglect, and serious losses of dignity and respect. Current evidence suggests that 1 in 10 older people experience elder abuse. Elder abuse can lead not only to physical injuries, but also to serious, long-lasting psychological consequences, including depression and anxiety. So let's talk a little bit about dementia. Dementia is a syndrome in which there is a deterioration in memory, thinking, behavior, and the ability to perform everyday activities. It mainly affects older people, although it is not a normal part of aging. It's estimated that 47.5 million people worldwide are living with dementia. The total number of people with dementia is projected to increase to 75.6 million in 2030 and 135.5 million in 2050, with the majority of sufferers living in low and middle income countries. There are significant social and economical issues in terms of the direct costs of medical, social, and informal care associated with dementia. Moreover, physical, emotional, and economical pressures can cause great stress to families. Support is needed from the health, social, financial, and legal systems for both people with dementia and their caregivers. Now, what about depression? Depression can cause great suffering and leads to impaired functioning in daily life. Unipolar depression occurs in 7% of the general elderly population, and it accounts for 7.5% of years living with disabilities among those over 60 years old. Depression is both underdiagnosed and undertreated in primary care settings. Symptoms of depression in older adults are often overlooked and untreated because they coincide with other problems encountered by older adults. Older adults with depressive symptoms have poorer functioning compared to those with chronic medical conditions such as lung disease, hypertension, or diabetes. Depression also increases the percentage of poor health and the utilization of medical services and healthcare costs. It is important to prepare healthcare providers and societies to meet the specific needs of older adult populations. This can be done by training health professionals in care for older persons, preventing and managing age-associated chronic diseases, including mental, neurological, and substance use disorders, designing sustainable policies on long-term care and palliative care, and developing age-friendly services and settings. So how can we promote health? The mental health of older adults can be improved through promoting active and healthy aging. Mental health-specific health promotion for older adults involves creating living conditions and environments that support well-being and allow people to lead healthy and integrated lifestyles. Promoting mental health depends largely on strategies which ensure the elderly have the necessary resources to meet their basic needs, such as providing security and freedom, adequate housing through supportive housing policy, social support for older populations and their caregivers, health and social programs targeted to vulnerable groups, such as those who live alone, and rural populations, or those who suffer from a chronic or relapsing mental or physical illness. Programs to prevent and deal with elder abuse, and community development programs. Prompt recognition and treatment of mental, neurological, and substance use disorders in older adults is essential. Both psychosocial interventions and medicines are recommended. There is no medication currently available to cure dementia, but much can be done to support and improve the lives of those living with dementia, their caregivers, and families, such as early diagnosis in order to promote early and optimal management, optimizing physical and psychological health and well-being, identifying and treating accompanying physical illness, detecting and managing challenging behavioral and psychological symptoms, and providing information and long-term support to caregivers. Good general health and social care is important for promoting older people's health, preventing disease, and managing chronic illness. Training all health providers in working with issues and disorders related to aging is therefore very important. Effective community-level primary mental health care for older adults is crucial. It is equally important to focus on the long-term care of older adults suffering from mental disorders, as well as to provide caregivers with education, training, and support. An appropriate and supportive legislative environment based on internationally accepted human rights standards is required to ensure the highest quality of services to people with mental health illness and their caregivers. That's all from me. Enjoy the rest of the show.
Hello, listeners. I'm going to talk to you all a little bit about residential care. Now, as Sophia discussed, the home is best. However, depending on a person's situation, care at home may not be ideal. So long-term residential care. Long-term residential care services provide 24-hour professional supervision and care in a protective, supportive environment for people who have complex care needs and can no longer be cared for in their own homes or in an assisted living residence. Long-term care residential care services include standard accommodation, development and maintenance of a care plan, clinical support services, ongoing planned physical, social, and recreational activities, for example, exercise, music programs, crafts, and games, meals, including therapeutic diets prescribed by a physician, and tube feeding, meal replacements and nutritional supplements as specified by the care plan or by a physician, routine laundry services for bed linens, towels, washcloths, and all articles of clothing that can be washed without special attention to the laundering process, general hygiene supplies, including but not limited to soap, shampoo, toilet tissue, and special products required for use with facility bathing equipment, routine medical supplies, incontinence management, basic wheelchairs for personal exclusive use, basic cleaning and basic maintenance of wheelchairs, and many other specialized services, for example, specialized dementia care or palliative care, as needed by the patient that the service provider has been contracted to provide. If you require long-term residential care services, supportive and compassionate care is provided in residential care facilities with the goal of preserving an individual's comfort, dignity, and quality of life as their needs change, and to offer ongoing support for family and friends. So, is certain care right for you? Well, long-term residential care services are for people who can no longer be cared for in their own homes or in an assisted living residences, and have severe behavioral problems on a continual basis, are cognitively impaired, ranging from moderate to severe, are physically dependent with medical needs that require professional nursing care, and a planned program to retain or improve functional ability, or are clinically complex with multiple disabilities and/or complex medical conditions that require professional nursing care monitoring and/or specialized skilled care. What are the long-term residential care eligibility criteria? Well, in addition to the general eligibility criteria for home and community care services, to be eligible for residential care services, you have to have been assessed as having 24-hour professional nursing supervision and care needs that cannot be adequately met in your home or by housing and health services, are at significant risk by remaining in your current living environment, and the degree of risk is not manageable using available community resources and services, have an urgent need for residential care services, have been investigated and treated for medical causes of disability and dependency that may have been remedial, have a caregiver living with unacceptable risk to their well-being, have a caregiver who is no longer able to provide care and support, or do not have a caregiver available. Will accept the first appropriate bed available where your preferred facility or location could not be accommodated on admission. Have consented to admission to the facility and agreed to occupy the bed within 48 hours of notification of availability of the bed, unless alternative arrangements have been made in advance with your health authority. And have arranged to pay your assessed rate and any additional optional charges for services, programs, or supplies that are not included as a benefit but are offered by the service provider. If you are interested in receiving long-term residential care services or know someone who might be in need of these services, you can contact your health authority's home and community care office, or you can have a healthcare professional make a referral for you on your behalf. If you are a veteran and you are eligible for home and community care services, your health authority is required to contact Veteran Affairs Canada for an assessment of eligibility for federal benefits and arrange your placement on their Veterans Priority Access bed waitlist in those facilities with Veterans Priority Access beds. If you and the health authority professionals working with you determine that you qualify for publicly subsidized residential care services, then you will be offered a bed based on the urgency of your care needs and other factors, including your facility preferences, availability of caregivers and community supports, your clinical care needs, appropriateness of the facility, and potential risk from abuse, neglect, or self-neglect in present living situation arising from ability of the client and or the caregiver to manage their health and daily living needs. Priority access to residential care beds means that you will be expected to accept the first appropriate bed that becomes available and is offered to you. Once you and your family are informed that the bed is available, you are expected to move into the facility within 48 hours. Publicly subsidized beds are in high demand, so it's important that they are used by those who need them. Health authorities try to accommodate individual needs and move clients into a facility that is their first choice. However, as the goal is to find a residential care facility that meets the care needs for people at risk as quickly as possible, sometimes individuals are not placed in the facility that is their first choice. In these situations, transfer to the preferred facility will be managed in an equitable manner. If you or your family believe that there may be difficulties being able to move in within 48-hour time period, alternative arrangements can be made with your health authority. Please speak to your healthcare professional about your circumstances. You may also want to talk to your healthcare professional if you have concerns about managing your costs while you transition from home to residential care facility. So what about couples in residential care? When both people are eligible for residential care, the healthcare authority makes every effort to place couples in a facility together. When only one member of a couple is eligible, and the couple wishes to stay together, the health authority will explore with the couple those options that may help to maintain their relationship. Health authorities will work with spouses to identify reasonable arrangements that would enable them to maintain and support their relationship. Your healthcare professional will determine which facilities best meet your individual care needs. It is important to discuss with your family which facility you prefer. It is advisable that you visit prospective facilities. Tours need to be scheduled in advance with the residential care facility staff to ensure someone is available when you arrive. There are many things to consider as you plan for your future care needs. In BC, residential care services and support options are available from both publicly subsidized and private pay service providers. If you have any questions, you can go to HealthLink BC, where they have a booklet containing information about eligibility, costs, services, oversight, and practical examples of things to consider when selecting a residential care facility. Many facilities have an information brochure or package that provides an overview of their philosophy, services, and answer many of your questions. Ask for the admissions agreement or similar documentation. An admissions agreement will clarify what services are provided, what services are not available, and any extra charges that may apply. Many facilities also have their own websites. To learn more about residential care facilities in Vancouver Island, visit the residential care pages on the Island Health website. So how do you transfer to your preferred facility? Well, every effort is made to offer you a bed in your preferred facility. Sometimes you may first be offered a bed in a facility that is not your first choice. If you find yourself in this situation, please speak with your healthcare professional, or once in the facility, with the director of care, facility liaison, residential care coordinator, or social worker. They will work with you to add your name to their transfer list for your preferred facility, if appropriate. You may change your mind at any time if you want to stay at your current facility. The amount of time you wait before you are offered the opportunity to transfer to your preferred facility will depend on a number of factors, including the number of people who are also waiting to transfer to that facility. If you are paying privately for residential care while waiting for access to publicly subsidized care, you cannot be guaranteed your subsidized bed will be in the same facility. If the facility that you are living in has subsidized beds, you can identify that facility as your preferred choice for placement. All individuals applying for residential care services must accept the first appropriate bed offered. However, if you are offered a bed in a facility that is not your first choice, as mentioned before, you may request a transfer once you have been admitted to a publicly subsidized bed. Choosing to pay privately for residential care should not impact the length of time you wait for your initial placement in a subsidized care facility. If you have concerns with the length of time that you have been waiting for initial placement, you should raise your concerns with your healthcare professional. Health authorities post summary inspection reports on their websites for routine and follow-up inspections of facilities licensed under the Community Care and Assisted Living Act, or licensed or designated under the Hospital Act. The reports include information relating to the substantiated complaints and inspections. So, is there a cost for long-term residential care services? If you receive publicly subsidized long-term residential care services, you will pay a monthly rate of up to 80% of your after-tax income towards the cost of housing and hospitality services, subject to a minimum and maximum monthly rate. Your monthly rate is calculated based on your after-tax income, as defined in the Continuing Care Fees Regulation, in one of two ways. If your after-tax income is less than $19,500 per year, your monthly rate is calculated as your after-tax income less $3,900 and divided by 12. The $3,900 deduction, which ends up being $325 per month, is set out to ensure that most clients have at least $325 of income remaining each month after paying their monthly rate for residential care. If your after-tax income is equal to or greater than $19,500 per year, your monthly rate is calculated as your after-tax income multiplied by 80% and divided by 12. If you or your spouse are sharing a room in a residential care facility and are both in receipt of the Guaranteed Income Supplement benefit at a married rate, your monthly rate will be calculated based on your after-tax income, subject to a minimum and maximum monthly rate. For 2017, the minimum monthly rate for a couple sharing a room and both in receipt of the Guaranteed Income Supplement benefit at a married rate is $763.90 per person. So, who pays for the care? If payment of your assessed monthly rate would cause you or your family serious financial hardship, you may apply to your health authority for a temporary reduction in your monthly rate. If you have any more questions, you can contact your health authority in Nanaimo Island Health and talk to them about your options. Serious financial hardship means that payment of your assessed monthly rate will result in you or your spouse being unable to pay for adequate food, monthly mortgage or rent, sufficient home heat, prescribed medication, or other required prescribed healthcare services. So, what if you have health issues and are unable to manage your own care at home? However, you do not wish to enter a residential care facility or are perhaps not eligible for residential care? Well, community nursing is one available option to help you with these needs. Community nursing services are provided by a licensed nursing professional to clients in the community who require acute, chronic, palliative, or rehabilitative support. Services include assessment and nursing interventions such as education, wound care, medication management, chronic disease management, case care management, post-surgical care, and palliative care. Generally, community nursing services will be provided on a short-term basis, and the community nurses will assist you and your family to be confident in taking over your care at home. Community nursing services may be provided in a variety of settings, such as clinics, the client's home, assisted living residences, family care homes, group homes, or other community settings. Is this care right for you? Well, services are available on a non-emergency basis for individuals in the following circumstances: following discharge from an acute care hospital, at home, or in a clinic setting to prevent or reduce the need for hospital or emergency department services, or admission to a residential care facility because of a life-limiting illness, or to meet time-limited acute nursing needs. You are eligible for community nursing services if you meet the general eligibility criteria for home and community care services. Your assessment for home and community care services determines that you would benefit from the service, and you meet all of the following criteria. Care can be provided with reasonable safety within established standards, policies, and guidelines for nursing practice. Staff are adequately prepared to manage any of your specialized nursing functions and/or technological needs. Your behavior and/or home environment does not jeopardize the safety of the community nursing staff. Potential risks have been assessed, and any necessary risk mitigation strategies can be successfully implemented. You or your family agree to participate in self-care activities as appropriate, considering such factors as current health and functional status of both you and your caregiver, willingness to participate in activities identified in the care plan, participation in planning for discharge from the services, and mobility. Thanks for listening. Up next, Brittany to share some good news.
And now for some good news.
If you're just tuning in, you're listening to 101.7 CHLY Radio in Nanaimo. My name is Brittany, and here is some good news. The Nanaimo Disability Resource Center, NDRC, is a not-for-profit charity serving seniors and people with disabilities since 1990. A Sound Constitution got in touch with Christina Young to talk about the services they provide. Here's the interview.
So I'm sitting here with Christina Young at Nanaimo Disability Resource Center located on Departure Bay Road. Thanks for taking the time to talk with the Sound Constitution. Would you mind telling the audience a bit about your role at the center before we get started?
I've been here for 7 years now, and I have several roles, one of which is the volunteer coordinator, so I recruit and train and manage the volunteers. I also coordinate the computer programs, so all of our programs that we offer to seniors and people with disabilities, I'm either teaching or coordinating in some way.
Oh, okay. Great. All right, so could you tell the listeners a bit about the services offered at NDRC?
We're a small nonprofit, so we have a lot of little tasks or little jobs that we do here. We distribute the parking placards for accessible parking spots through town, and we distribute those pretty much Duncan and north to Ucluelet and Tofino, Port Alberni and Port Hardy, all the way up the island. We have an information and referral service, so if someone's overwhelmed or doesn't know where to go, doesn't know who they should call to get services in the community or from the government, they can call us and we can help them navigate where to call or who to call or what the services available to them are. Mm-hmm. We have all of our computer classes, of course. We offer one-on-one and group training from things from cell phones and computers to iPad class and anything in between. We offer services to our people who are blind to learn to use a computer or their phone or braille notes, any devices from another person who's blind as well. And all those computer classes are free of charge to the students.
Great. Wow. Okay. In addition to helping people with disabilities, you also offer services to seniors, as you mentioned. So could you tell us more a bit about this?
Sure. A lot of seniors didn't grow up with computers, for instance, and they might be facing issues in their lives now that they haven't faced. So the resource and referral program is definitely targeted towards seniors as well as adults with disabilities. And again, the computer classes are open to people as seniors, who are seniors as well.
Mm-hmm. Great. Yeah, it's wonderful to get everyone connected. One last thing, the Seniors Connect. Can you tell me a bit about that program?
Sure. Seniors Connect is a group of 4 organizations in our community. We aren't one of the core 4, but we're involved with their action groups. So we were part of the group that got together with them last October to identify needs and gaps in services and causes of social isolation in seniors in Nanaimo. And from that, we've become part of 2 different action groups. One called the City Builders, trying to figure out if there's things we can add in the city that will help people get out more. For instance, we added a bus stop and a crosswalk in areas where people felt that there would be a lot of benefit to the people in those areas. The other one is the resources. So we're a part of an action committee that's trying to help people get better access to resources, helping to promote the idea of BC 211 and get people using it. We're creating a wallet-sized resource card that has about 70 different phone numbers on it of the key things that any senior might need in a pinch. So it would be the gateway numbers. So it wouldn't have everything that you need, but if you phone one of them, they should be able to get you to the resource you're looking for.
Is there anything else about the NDRC that you'd like to share with the listeners?
Well, we're a volunteer-driven organization, so we're always looking for keen and enthusiastic new volunteers to help with the different things going on here, whether it's the front desk reception or helping in computer classes or board members that are interested in thinking of new fun programs that we can offer the community. So
if they wanted to get in touch with you, would that be via your website?
Yes. On the website, there's our volunteer application. You could just click on the email us button and send me an email. Phone numbers there. Lots of ways to get in touch.
Perfect. Okay. And hopefully this will also get the word out. All right. Well, thanks again for taking the time to sit down with us, Christina. It's been a pleasure.
Oh, thank you.
A big thank you to Christina Young for taking the time to share information about the Nanaimo Disability Resource Centre. For more information on the NDRC, please check out their website at ndrc.info. If you're interested in the other resources Christina talked about, check out NanaimoSeniorsConnect.ca. That's NanaimoSeniorsConnect.ca or www.bc211.ca. And please check out our Facebook page for those links. You're listening to A Sound Constitution, and today we are talking about health and wellness in the older adult. Last season, we received a message from one of the previous A Sound Constitution hosts who asked us if we had considered touching on the subject of medical assistance in dying, MAID, or Bill C-14. We thought it was a great idea and a very important topic to cover, so thank you for the input. We often associate death and dying as the final chapter of a long life, however, this isn't always the case. Next, we've got a clip from Dying with Dignity Canada that offers the perspective of some health professionals about their experience with providing MAID. But before we continue, we recognize that MAID can be a controversial, complex, and emotionally charged topic for some people.
The very first time I provided MAID is still one of the benchmarks for me because it was such an extraordinary family that I was working with. So I remember a lot about that particular event and the lead up to it.
I was very anxious to do it well because I recognised that this was an enormous step for myself, my colleague who was assisting me. We set up our programme, the two of us, in our area together. So it's very important that we thought about everything, got everything right, worked out how to deal with the family.
The actual experience of being with Hannah Schaefer and her husband and friend was a wonderful experience. Hannah herself was relaxed and happy that she got to triumphant that she actually got to do what she had planned and wanted over many months.
When we got into the room to help this gentleman, it was actually a very small room. It was just his immediate family, and everybody just intuitively reached out to touch him. Everybody was touching him, including myself. I was managing what I was doing, and I was holding his arm, and each of his children and his wife, everybody had physical hands on him.
But it was a very complete sense of having taken him, I've been his doctor for 13 years, of having taken him through the last stage of his life and then being able to provide something that he desperately wanted and was now able to have.
And I was just about to start. I'd gone through all the procedure and the process and the consent and everything, and he had given me permission verbally, and we nodded, yes, he's ready, and we're about to start. And this colleague of mine was standing behind me. It was quite tight in the room, and I felt her reach out and touch my back. And she just laid her hand on my back just as I was about to administer the medication. And it wasn't until that moment that I realized, although I knew what was happening and I was in control of things, I really was still nervous. And when I felt her hand touch my back, I realized there was a true physical connection between every single person in the room. Everybody was touching someone, and they were mostly we're all touching him in that way. And I immediately relaxed and proceeded.
No, it was a very emotionally charged situation. The patient went peacefully. The wife cried, the sister-in-law cried, and I cried, and we hugged, but it was all good, you know, like I felt like I was doing the patient's wishes, and although it was a sad situation, there was a good self-gratification out of it. So I'm looking not forward, but I'm not looking with stress at the next one now. I think things will go well.
I've never really forgotten that moment. I've been very thankful that she did that. I didn't ask her to do that. I don't know why she did that. I was really glad that she did. And it went very smoothly, and people were very grateful. It was really a beautiful, beautiful event. But I'll never forget that.
That was a clip from Dying with Dignity Canada. Next, we've got another clip from The National with a look at 10 months after medical assistance in dying.
In January, John McTavish's husband Rob chose a medically assisted death.
Rob got into bed, and then the doctors came in, and 5 minutes it was over.
Rob Rowlands learned 2 years ago he had cancer.
He had no strength left. He would go to the floor, all kinds of just horrendous things.
Months of radiation, chemo, and surgeries left him unable to even eat.
There was really no quality of life. And on January 3rd of this year, he made the decision that he was done. So we contacted the doctor and set everything in motion that on the 6th of January, he would be able to end his life.
The end came with an IV and drugs prescribed by a doctor that flowed into his body. The physician also vouched that Rowland's death was reasonably foreseeable, as Canada's law requires. Since last June, at least 1,300 Canadians have chosen a medically assisted death. Vancouver Island has among the highest assisted death rates in Canada, with 100 deaths through the end of February, or roughly 2% of all the deaths on the island, suggesting a fairly rapid adoption rate, says Dr. Jonathan Regler.
I would say the law is working reasonably well.
Regler practices in Courtenay and has been personally involved in 10 such deaths. He believes even more people would opt for it if they weren't required by law to be aware and coherent at the time of their death.
I think that we should not insist that people have capacity right up until the very end. Apart from anything else, it's leading to patients having to forego painkillers whilst waiting for a medically assisted death, and that's wrong.
He typed this up on Thursday night.
McTavish says his husband wrote a letter just hours before he died.
And I could have never loved another as much as I have loved you.
It's a goodbye that increasingly many Canadians are choosing. Chris Brown, CBC News in Courtenay, BC.
That was a clip from The National looking at 10 months after the passing of Bill C-14. A Sound Constitution accessed provincial and federal resources for information regarding medical assistance in dying. MAID is now legal in Canada, as long as criteria established in the federal legislation are followed. In February 2015, the Supreme Court of Canada decided that it would no longer be a criminal offence in Canada for a physician to help someone end their life in certain circumstances. On June 17, 2016, the federal government passed legislation to amend the Criminal Code and bring medical assistance in dying into practice throughout Canada. Patients and their families have many decisions to make when faced with end-of-life care or intolerable suffering. It's important for British Columbians to know and understand all the health care options available to them. I will now cover a few questions that Canada.ca answers regarding medical assistance in dying. What if my doctor or nurse practitioner won't perform MAID? For a variety of reasons, not all doctors or nurse practitioners will provide medical assistance in dying, and no one will be forced to do so. For some, providing this service may conflict with their personal beliefs. Even if a doctor or nurse practitioner does not provide medical assistance in dying as a matter of conscience, a patient can still expect to be treated with respect and be provided with information on how to access this service. This means healthcare providers must not discriminate against patients and must provide an effective transfer of care if they choose not to offer that care themselves. What if I change my mind? Patients requesting MAID can change their mind and rescind their request at any time and in any manner. It is very important that patients have time to reflect on their decision. Following a patient's request for medical assistance in dying, a mandatory reflection period of at least 10 days must occur between the day the written request is signed and the day medical assistance in dying is provided, unless death or the patient's loss of capacity are imminent. Immediately before the doctor or nurse practitioner provides medical assistance in dying, whether in the form of administering or providing the patient with prescribed drugs for self-administration, they must confirm with the patient that they are still sure this is what they want, and the patient must provide consent to proceed. Can I request medical assistance in dying in advance of experiencing suffering or receiving a diagnosis? According to federal law, medical assistance in dying cannot be provided based on an advance request and can only be provided after 2 independent assessors have determined that all of the eligibility criteria set out in the Criminal Code have been met. Furthermore, in order to receive medical assistance in dying, a patient must be able to clearly communicate their consent at the time of the procedure. Only the patient can request and consent. Medical assistance in dying cannot be provided at the request of a substitute decision maker. For more information on the topic of MAID, visit www.gov.bc.ca. If you're just tuning in, you're listening to A Sound Constitution on 101.7 CHLY in Nanaimo, and we're talking about older adulthood. Up next, we've got a clip from Sophia. Off to you, Sophia.
Thanks, Brittany. To end on a light note and bring attention to the positives of aging, we have an audio clip from Laura Carson's TED Talk, Older People Are Happier. Let's see what this is all about.
People are living longer, and societies are getting grayer. You hear about it all the time. You read about it in your newspapers, you hear about it on your television sets. Sometimes I'm concerned that we hear about it so much that we've come to accept longer lives with a kind of a complacency, even ease. But make no mistake, longer lives can, and I believe will, improve quality of life at all ages. Now, to put this in perspective, let me just zoom out for a minute. More years were added to average life expectancy in the 20th century than all years added across all prior millennia of human evolution combined. In a blink of an eye, we nearly double the length of time that we're living. So if you ever feel like you don't have this aging thing quite pegged, don't kick yourself. It's brand new. And because fertility rates fell across that very same period that life expectancy was going up, that pyramid that has always represented the distribution of age in the population, with many young ones at the bottom, winnowed to a tiny peak of older people who make it and survive to old age, is being reshaped into a rectangle. And now, if you're the kind of person who can get chills from population statistics, these are the ones that should do it, because what that means is that for the first time in the history of the species, the majority of babies born in the developed world are having the opportunity to grow old. How did this happen? Well, we're no genetically hardier than our ancestors were 10,000 years ago. This increase in life expectancy is the remarkable product of culture, the crucible that holds science and technology and wide-scale changes in behavior that improve health and well-being. Through cultural changes, our ancestors largely eliminated early death so that people can now live out their full lives. Now, there are problems associated with aging. Diseases, poverty, loss of social status. It's hardly time to rest on our laurels. But the more we learn about aging, the clearer it becomes that a sweeping downward course is grossly inaccurate. Aging brings some rather remarkable improvements, increased knowledge, expertise, and emotional aspects of life improve. That's right. Older people are happy. They're happier than middle-aged people, and younger people certainly. Study after study is coming to the same conclusion. The CDC recently conducted a survey where they asked respondents simply to tell them whether they experienced significant psychological distress in the previous week, and fewer older people answered affirmatively to that question than middle-aged people, and younger people as well. And a recent Gallup poll asked participants how much stress and worry and anger they had experienced the previous day, and stress, worry, anger all decrease with age. Now, social scientists call this the paradox of aging. I mean, after all, aging is not a piece of cake. So we've asked all sorts of questions to see if we could undo this finding. We've asked whether it may be that the current generations of older people are and always have been the greatest generations. That is, that younger people today may not typically experience these improvements as they grow older. We've asked, well, maybe older people are just trying to put a positive spin on an otherwise depressing existence. But the more we've tried to disavow this finding, the more evidence we find to support it. Years ago, my colleagues and I embarked on a study where we followed the same group of people over a 10-year period. Originally, the sample was aged 18 to 94. And we studied whether and how their emotional experiences changed as they grew older. Our participants would carry electronic pagers for a week at a time, and we'd page them throughout the day and evenings at random times, and every time we paged them, we'd ask them to answer several questions on a 1 to 7 scale. How happy are you right now? How sad are you right now? How frustrated are you right now? So that we could get a sense of the kinds of emotions and feelings they were having in their day-to-day lives. And using this intense study of individuals, we find that it's not one particular generation that's doing better than the others, but the same individuals over time come to report relatively greater positive experience. Now, you see this slight downturn at very advanced ages, and there is a slight downturn, but at no point does it return to the levels we see in early adulthood. Now, it's really too simplistic to say that older people are happy. In our study, they are more positive, but they're also more likely than younger people to experience mixed emotions. Sadness at the same time you experience happiness. You know, that tear in the eye when you're smiling at a friend. And other research has shown that older people seem to engage with sadness more comfortably. They're more accepting of sadness than younger people are, and we suspect that this may help to explain why older people are better than younger people at solving hotly charged emotional conflicts and debates. Older people can view injustice with compassion, but not despair. And all things being equal, older people direct their cognitive resources, like attention and memory, to positive information more than negative. If we show older, middle-aged, younger people images like the ones you see on the screen, and we later ask them to recall all the images that they can, older people, but not younger people, remember more positive images than negative images. We've asked older and younger people to view faces in laboratory studies, some frowning, some smiling. Older people look toward the smiling faces and away from the frowning, angry faces. In day-to-day life, this translates into greater enjoyment and satisfaction. But as social scientists, we've continued to ask about possible alternatives. We've said, well, maybe older people report more positive emotions because they're cognitively impaired. We've said, could it be that positive emotions are simply easier to process than negative emotions? And so you switch to the positive emotions. Maybe our neural centers in our brain are degraded such that we're unable to process negative emotions anymore. But that's not the case. The most mentally sharp older adults are the ones who show this positivity effect the most. And under conditions where it really matters, older people do process the negative information just as well as the positive information. So how can this be? Well, in our research, we've found that these changes are grounded fundamentally in the uniquely human ability to monitor time. Not just clock time and calendar time, but lifetime. And if there's a paradox of aging, it's that recognizing that we won't live forever changes our perspective on life in positive ways. When time horizons are long and nebulous, as they typically are in youth, people are constantly preparing, trying to soak up all the information they possibly can, taking risks, exploring. We might spend time with people we don't even like because it's somehow interesting. You know, we might learn something unexpected. We go on blind dates. You know, after all, if it doesn't work out, there's always tomorrow. People over 50, don't go on blind dates. As we age, our time horizons grow shorter and our goals change. When we recognize that we don't have all the time in the world, we see our priorities most clearly. We take less notice of trivial matters. We savor life. We're more appreciative, more open to reconciliation. We invest in more emotionally important parts of life, and life gets better. So we're happier day to day.
Well, there you have it. We could learn a lot about living positively from the older adult population. You've been listening to A Sound Constitution on CHLY Radio. Thanks for tuning into our health promotion show today. We hope you have a takeaway nugget for yourself or to share with someone in your life. We have so enjoyed traveling through the lifespan with you guys this season. Don't forget to visit our Facebook or YouTube page for podcasts of all of our shows and links to some useful resources that we shared. Until next week, stay healthy, Vancouver Island.
Thanks for listening to A Sound Constitution on 101.7 CHLY Radio.
For more information, questions, or comments, please visit our Facebook page at A Sound Constitution.
Tune in again next Thursday morning from 10 to 11.
Stay healthy, Vancouver Island.